Okay, so we are doing T-cell lymphoma, which means we got lots of time to do potpourri too, because some of the T-cell stuff we have covered earlier in the year in interface dermatitis. Okay, everybody in? So I'll walk you through the first one. We have an infiltrate mainly around the vessel. Not a whole lot of epidermotropism. In fact, to the point where I don't particularly like this one to discuss, other than there is some lymphoid atypia and angulation of lymphs. Lymphs should be round, not square, not triangular. So angularity of lymphocytes helps. The other thing that used to be done and still works is if you cut very thin sections, look at the number of indentations in the nucleus. If there are 5 or more indentations in the nucleus, it's probably MF, statistically. So it's a cerebriform nucleus with indentations, and simply counting the indentations helps as an assessment of atypia. Okay. So let's look at this one and tell me at a glance about these lymphocytes in the epidermis versus those lymphocytes down there. These are little... Okay, go ahead.
The ones in the epidermis are larger.
They're not particularly darker in this case because they're kind of gray, right? But you see some visible mitotic figures in the epidermal lymphocytes, and they're certainly much larger than the lymphocytes down below, which are, maybe half the size. Hard to judge papillodermal fibrosis when the infiltrate really abuts the papillodermis. Looking at the perivascular infiltrate, you can make out some vessels where it's clear that the infiltrate is on the top side of the vessel and there's really not much below the vessel. That's the bare underbelly sign, which goes with mycosis fungoides. And then if you look at the lymphs in the epidermis and you take a little closer look, you can see lots of little indentations in the... See how that's serrated at the edge there? Can you make that out?
Oh, yeah.
This is probably about a 7-8 micron thick section. If you cut it 1 micron thick, you can see that they're cerebriform. And that cerebriform morphology with multiple indentations is very helpful diagnostically. So nice thin sections for MF makes it easier to pick out the atypia. Beyond size and hyperchromasia, there's also the outline that it's a cerebriform nucleus, which in the usual thick section just means you can make out various indentations and points on the nucleus. So like when you look at this guy, see how up top it's got some pointy things sticking out? 2 little horns there. So that all of that sort of thing counts as lymphoid atypia. So epidermotropic infiltrate, lymph in every hole. There's really not much difference between epidermotropism and exocytosis in terms of how the words are defined, but the way they're used, epidermotropism is what you use when it's MF, and exocytosis is what you use when it's dermatitis. so that MF would have little associated spongiosis. Too much infiltrate for too little spongiosis, whereas you tend to have lots of spongiotic vacuoles in a dermatitis. You can make out here a little bit of dense collagen. That's about as close as you're getting to being able to see papillodermal fibrosis in that particular case. Okay. How about this one?
So I think we have some epidermal tropism, interface dermatitis with a lymph in every hole.
So it's definitely a lymph in every hole pattern, right?
And
Tell me about the reedy.
we see a thin, elongated.
Thin and elongated. Is that what normally happens in MF?
I don't think so.
No, it's usually just the opposite, right? You get effacement. So we got something else that mimics MF. It's got a lymph in every hole, but there's something screwy here because you have elongation of the reedy. Any thoughts?
Syphilis is a thought. Syphilis.
Syphilis, which is exactly what it is, right? So part of diagnosis of MF is differentiating it from the things in the differential diagnosis, right? So clue here is that you have long, slender, sexy, if you will, reedy ridges that certainly goes with, better with syphilis than with MF. Okay.
So, looks like there's a lymphoid infiltrate. It's not as dense as before, but it does look vacuolar.
Looks vacuolar.
Looks like there's a lymph in every hole. Maybe like a collection of them kind of in the epidermis, like of atypical lymphocytes, like a Potrier microabscess.
So suggests the possibility of MF, right? You got a lymph in every hole, you got little collections in the epidermis. Tell me about that cell, that red cell with the dark black nucleus in it.
Was it an EO?
And then this one here, and that one there, and that one there.
Oh, there's atypical.
Or no, they're necrotic keratinocytes. So they're apoptotic cells, we say dead reds, right? So if you want to know what death will look like, it's red, at least in H&E. Right? So anything dead stains red. So necrotic keratinocytes, dead, and then you get a pycnotic nucleus in the center. If the differential is early MF, necrotic keratinocytes and eosinophils are incredibly rare. So EOs in an infiltrate really points away from MF unless it's folliculotropic or plaque tumor. So plaque and tumor, by tumor stage, you got tons of EOs. Anything that's folliculotropic MF has tons of EOs. But your regular early patch MF, which is where you're usually struggling to make the diagnosis, EOs really point away from MF pretty strongly. Dead reds point away from MF, except for hypopigmented MF in kids, which is usually a CD8 cytotoxic profile, which can occasionally have dead reds. And then aggressive epidermotropic T-cell lymphoma. So the aggressive epidermotropic T-cell lymphoma, you have an epidermotropic infiltrate with atypia, lots of dead reds because it's a cytotoxic phenotype, and within 3 months you're dead, looking like toxic epidermal necrolysis. Right? So it's a distinct clinical presentation. So if you're struggling with patches on the trunk and abdomen and you see this, that's not MF, right, with the dead reds. Because if you were aggressive epidermotropic T-cell, cytotoxic T-cell lymphoma, it would be a rapidly progressive course with demise and widespread epidermal necrosis, sepsis, death. So it just doesn't fit the clinical. So that suggests, probably not MF in this case. So EOs go against early MF. Dead reds go against early MF. In this case, this was eruption of lymphocyte recovery after a bone marrow transplant. Your typical viral exanthem, drug exanthem, they're all interface. And sometimes they're a lymph in every hole, or, roughly equal holes in limbs. This one actually has quite a few. If you go to some areas, there are quite a few holes with no lymphs in them, which is a clue that it's not MF, right? Lack of papillodermal fibrosis, holes out of proportion to lymphs. When you look at the perivascular infiltrate, it's on both sides of the vessel, not just on the top side of the vessel. There's no bare underbelly sign. Dead reds, EOs, they can all help you differentiate between other interface. Clinically, the best thing to do is how big is the rash? If it's bigger than your palm and it's on sun-protected areas, especially limb girdle areas, axilla, butt, upper back, lower abdomen, and they're palm-sized patches, that's probably MF. If it's not palm-sized, not 5 centimeters or greater, it's probably not MF. Okay. So that, that's a big help clinically when you're trying to navigate through them. Okay, well, there we go. These sections are a little more intact. Let's see if we got a whole ribbon here. Somewhere in that ribbon we're going to have some nice intact sections. Let's also color here. There we go. It's a little chewed up the whole way, but you still should be able to see.
It's all like either ulcerated or tissue prep artifact.
Yeah, probably tissue prep artifact.
Maybe vacuolar, some big cells.
And
Tropism.
tell me about holes and lymphs.
There's a lymph in most of the holes.
Yeah, I'd say it's pretty much a lymph in every hole. What's that cell there and this cell here?
An angulated lymphocyte.
Oh, there are angulated lymphocytes, but see how there's a dead red next to it, dead red here. So that again suggests probably not MF.
How about this LYP have any dead reds?
LYP, it depends on the type. There are lots of different types of LYP. There's one that can mimic the epidermotropic cytotoxic T-cell lymphoma, aggressive epidermotropic cytotoxic T-cell lymphoma. So there is one type that can do more of that. What are all these red things?
Extravasated red.
Yeah, so you got extravasated erythrocytes, and then when you look along that stratum corneum, you got some clusters of neutrophils. So you got a little bit of a scale crust on this. It's a lymph in every hole pattern. There's some dead reds.
Like a PLC.
This would be pretty good for pityriasis lichenoides, especially with the red cell extravasation. So a lot of it is working through the differential diagnosis. So it's scan. What's going on here?
There's interface change.
And I'd say roughly at scan, it looks like a lymph in every hole.
Mm-hmm.
And then your superficial and deep infiltrate, which MF does. And let's go a little higher. There's certainly papillodermal fibrosis, right?
Yes.
There are collagen bundles above the postcapillary venule. What's with all of these little round things? And little segmented bodies here.
Are those neutrophils?
There are neutrophils. In fact, there are a lot of neutrophils here. So, do neutrophils usually go with MF?
I don't think so.
No, I mean not unless they're, not unless it's ulcerated, and we don't see any ulcer here. So there's no explanation for why there'd be neutrophils. So we have an epidermotropic lymph in every hole type infiltrate. The epidermis is kind of effaced. There's papillodermal fibrosis. So all that was looking good for MF. But we got a problem in that there's a polymorphous infiltrate. Not only are there newts, but there are EOs here too. So newts and EOs, both of which don't really go with MF. So what would be interface, can be lymph in every hole, can have papillodermal fibrosis, but has a polymorphous infiltrate. One of the other clues is that it's interface dermatitis, but the pigment incontinence is down below the fibrosis. That pigment is deep. It's had time to take the crosstown bus.
So, could it be folliculotropic MF because there are EOs in
So folliculotropic MF absolutely could have EOs. Doesn't tend to have the neutrophils, right? And we see most of the epidermotropism in the epidermis, not in the follicles, right? Folliculotropic, it really would be in the follicles.
Polymorphic drug.
So what kind of drug? Fixed drug. So fixed drug can be lymph in every hole. It has papillodermal fibrosis, so that can mimic MF, right? But it tends to have a polymorphous infiltrate. So first off, no lymphoid atypia, no bare underbelly sign. The infiltrate is polymorphous, and you have deep pigment that's had time to take the crosstown bus and get down around deeper vessels because this is a recurrent phenomenon. This is awfully deep to have pigment in anything that's an acute process, right? So deep pigment is a clue, lack of a bare underbelly sign, and the polymorphous infiltrate. Also, MF usually has a more compact corneum. That's a very acute looking corneum, right? So that's kind of a disconnect with the papillodermal fibrosis. So, clue for fixed drug.
Some kind of tangential cut.
So tangential cut.
But it does look like a little canthrosis.
So there's a little bit of acanthosis. Your corneum, acute or chronic?
Chronic and lymph in every hole, and seems the lymphs have indented.
So
Unrelated.
some indented nuclei. That one looks like a boomerang right there. So indented nuclei, papillodermal fibrosis, lymph in every hole, chronic corneum, probably MF. You want to look at the patient and see, are these palm-sized lesions, limb girdle area, bathing suit area? That would be good for mycosis fungoides. Okay. Shoe fun. So epidermotropic infiltrate.
Yeah.
Does your corneum look compact, or is it basket weave? Basket weave, so that's not really MF, right? So basket weave corneum already gets you worried that maybe you're not dealing with MF. And then how much epidermal death is there in proportion to the lymphoid infiltrate? Lots of death out of proportion to lymphs, right? So whereas at the edge, you could maybe talk yourself into lymph in every hole, you get to more developed areas, there's a lot of death out of proportion to lymphs. So death out of proportion to lymphs, acute corneum, lymphoid infiltrate. So erythema multiforme would be most likely, or EM to EN type differential. So death out of proportion to lymphs, acute horn, point to erythema multiforme rather than MF. So lots of EOs. So what does that make you think in terms of MF?
No.
Probably not MF, right? Lots of papillodermal fibrosis. So BP would be a thought, but BP usually doesn't have much papillodermal fibrosis. This has a lot. Look how your superficial papillary plexus is shifted down by all this dense collagen. So you have a lot of papillodermal fibrosis, and yet your corneum, does that look like a chronic corneum? So fixed drug eruption again. So clues that it's not MF, polymorphous dermal infiltrate. You've got papillodermal fibrosis, but your corneum's acute. So you have that disconnect. Leads you to fixed drug rather than MF.
There's a compact parakeratosis,
So compact parakeratosis,
which wouldn't be normal for MF.
which is not usually for MF. MF is usually just a compact orthokeratotic horn. You do have, looks like, lymph in every hole pretty much.
Yeah.
Epidermis isn't faring too well, looks pretty ugly.
Yeah. And a perivascular infiltrate.
There is a perivascular infiltrate. It's not particularly top heavy. It's symmetrical around the vessels, so you don't have a bare underbelly sign. Not really seeing papillodermal fibrosis. Well, maybe a tiny little bit there, but not much. You've got some neutrophil debris in the horns, so you got sort of a dirty scale crust. And you've got some dead reds. So interface dermatitis, dead reds, lymph in every hole, scale crust.
So I'm thinking of the P-Tix differential and trying to figure out which has dead reds in it. Is that the wrong way to go about this?
No, P-Tix. But this is one we never think of with P-Tix because the other features are so characteristic. Pityriasis lichenoides pleva versus PLC. Pleva has a dirty scale crust.
Gotcha. Okay.
There's so many other things pointing to pleva that P-Tix is kind of where the only thing you have is newts in the horn. But so this would be good for pleva rather than MF. with the scale crust being part of it. This is another pleva. So this would be sort of a typical pleva. Thick scale crust, lymph in every hole, usually no papillodermal fibrosis, infiltrate superficial and deep, no bare underbelly, and no lymphoid atypia, but lymph in every hole, scale crust, with or without erythrocyte extravasation. Helpful clue if it's there, you don't always see it. Okay, so that would be a good pleva versus MF. And this one, your epidermis, we're going to skip that because it's mainly just epidermis. You don't see what's under. Let's go ahead. Okay, so your question is MF, not MF.
I'm going with MF.
I'm sorry, you're going with MF? Okay, so why are you going with MF?
So it is interface dermatitis. And you have some atypical lymphocytes, large size angulated.
You have papillodermal fibrosis, where you have your infiltrate around the vessel. Is it symmetrical or do you have a bare
You
underbelly?
have the top heavy infiltrate.
So top heavy infiltrate, epidermotropism, lymph in every hole. The corneum's getting a little bit thick and compact, so that's kind of good. Hyperkeratosis, papillodermal fibrosis. So you're going with MF? I agree. I think that's pretty good for MF. Okay, how about this one?
So it looks like there's some like spongiosis.
There's a lot of spongiosis in this one, right? So that's something that makes you question MF.
Right.
Is there papillodermal fibrosis?
There is.
It's definitely something chronic. You've got, so then the next question is, do you see lymphoid atypia?
Yes.
Yeah, big time lymphoid atypia, right? Let's try to get, oop, we are frozen up on the screen. Okay, we'll just carry on. So big time lymphoid atypia. And then tell me about the dermal lymphocytes.
We're looking.
There are some very atypical lymphocytes in the dermis as well. You also have small, normal recruited ones, but you're starting to get EOs. So do EOs go with early MF?
No.
Do they go with tumor MF? They sure do, right? And when you start getting big things like this with nucleoli, with visible nucleoli, that's CD30 degeneration, transformation of MF. So it's going tumor stage. Most tumor MF, as it transforms, it's very common for it to be CD30 positive. And they start looking like Reed-Sternberg cells often, which is characteristic of CD30 positive lymphocytes. Big cells, prominent nucleoli. There now is monoclonal antibody that is anti-CD30. So there are two monoclonals now for treatment of MF. One that's anti-CD30 and one that's we have to look it up, it's like 51 or something, but it's something that MF cells tend to express. So you now have two targeted therapies for MF. So we have all the things we normally do: retinoids, light, low-dose methotrexate, to treat most of our patch and plaque MF. But as MF progresses and the prognosis worsens and you start getting tumors, conventional chemo hastens death because it blows away your immune system. You no longer contain the MF and you die more quickly, not less quickly. So you get temporary regression of the lesions and then death. So conventional chemo contraindicated in MF. There are a few targeted things like vorinostat, ONTAC that you can use, but the new thing is you have monoclonal antibodies. They can bind the transformed cells or the MF cells, and they will be the way of the future for treating refractory advanced cases of MF.
Have you used it yet, that medicine? The CD30, the anti-CD30 monoclonal?
I'm sorry, say again?
Have you given it, have you prescribed it to anyone or seen it work with anyone?
I have done it, not that commonly, but yes, I have. And I've actually prescribed both. I prescribed the other one for the first time just last week. It was just released in August.
Oh, so it's super new.
Yeah, so it's new, but you're definitely gonna see it. Okay, so is this an epidermotropic infiltrate?
No, it's almost a little bit of a Grenzone, but it's really diffuse and really
Yeah,
deep.
Grenzone, and it's diffuse and it's deep. So that's not a T pattern, that's a B pattern. Right? So that's a B lymphoma in pattern. This is a patient with known MF who gets new nodules. But these nodules are, you can see the MF above. The new nodules are kind of vertically oriented, so oval and vertically oriented. See how if they're taller than they are round and they tend to follow follicles? That's a B pattern. This is a secondary B lymphoma in an MF patient. 10% of MF patients get a secondary lymphoma. Usually it's CD30 degeneration, transformation, but they can also get B lymphomas. B lymphomas tend to be diffuse or sheet-like infiltrates. They're either nodular or vertically oriented. Vertically oriented in gray is more likely to be marginal zone lymphoma. So those are all things that you'll hit next week. Let's see, we've got some of the other things that we need to... Okay, let's do this.
This one's also very diffuse and very deep.
Very diffuse, but is it really diffuse or is there collagen between?
Collagen.
The B lymphomas don't have collagen between. They push the collagen out of the way. Okay, so they're sheets of cells. This is something interstitial with collagen in between. They're granulomas, right? So this is a heavy lymphoid infiltrate with granulomas. There's epidermotropism, they're portray microabscess. You can see you've got that huge collection of lymphocytes. Where's the spongiosis for that huge collection of lymphocytes? Not there, right? So too much for too little, that's the one that inappropriately was called the Dolly Parton sign, was too much for too little. So you'll hear that expression, Dolly Parton sign, right? It's definitely not PC, but you will hear that, and just so you're not left saying, well, I've never heard of that before, that's what they're referring to, right? Is too much infiltrate, too little spongiosis. So again, you've got epidermotropism, a real collection of lymphocytes with really no or very little spongiosis around it. That would be pretty good for MF, right? But then you've got this infiltrate that's not really diffuse or sheet-like. It's all through the dermis, and then there's granuloma associated. This is absolutely granulomatous MF. Okay. So it's different from a B pattern.
You mean, is it the same thing as slack skin?
Granulomatous slack skin is
Yeah.
different.
Oh, okay.
So there's granulomatous MF, that's just granulomatous MF, and then there's granulomatous slack skin. Granulomatous slack skin has massive giant cells. I mean, giant cells that are like as big as a hair follicle. And then it's a very typical characteristic appearance. You've got these big saggy things in your axilla and groin because it wipes out the elastic. So it's a clinical pathologic correlation that helps establish the diagnosis. So, okay, we're going to do a couple more things here. Okay, so this. You don't see a lot in the epidermis, right? It's all around the follicle, and you can see all those cells clustering in the follicular epithelium. You've got some papillodermal fibrosis adjacent to the follicle, so you have a little Grent zone adjacent to the follicle. Lots of epidermotropic lymphocytes. Very little spongiosis in the follicle.
So this would probably be folliculotropic MF.
Folliculotropic MF, and then in this, do you get EOs or no EOs?
You do get ears.
And in fact, you can see it's loaded with EOs in here. So that's folliculotropic MF. This came in with a history, rule out psoriasis. It's an isolated keratotic plaque, lower extremity.
Like a noise interface.
So there's a epidermotropic, heavily epidermotropic infiltrate. In areas it's so heavy that it looks like your epithelium's eaten away. I don't see a lot of dead reds though. It's when you look, there's actually a smooth outline, not really sawtoothing. It's just that most of it's taken up by large atypical lymphocytes instead of the epithelium. They're Potrium microabscesses, the cells are angulated. So there's a massive epidermotropic infiltrate. Looks like MF from hell, right? But it's one solitary hyperkeratotic lesion on the lower extremity.
Okay.
Worringer collop.
Was it the pagetoid reticulosis?
Pagetoid reticulosis. So pagetoid reticulosis of Worringer and collop is a localized unilesional epidermotropic MF where you usually have a massive epidermotropic tumor load, but one isolated keratotic lesion on the limb. And it's a type of MF where sometimes the best way to treat it is cut that off. Excise it or narrow band or electron beam just that, fry or cut out that one lesion because it's isolated to that one lesion and can be cured that way. So this one, you see clusters of large atypical lymphs in the epidermis, heavy epidermotropic infiltrate, but down below you have all of these very large atypical cells, many of which have nucleoli. So this would be typical of transformed MF, large cell transformation.
If it was just like ALCL, would you not have the epidermal involvement?
Correct.
Okay.
So ALCL has sheets of anaplastic large cells, but it doesn't have epidermotropism. This has a background of MF and then has transformed CD30 positive cells. So for CD30, we always say CD30 lymphoproliferative condition or disorder. So CD30 lymphoproliferative disorder, because without the clinical, you don't know, is it LYP? Is it ALCL? Is it transformed MF? You don't know without the clinical. You got to look at the patient to know what the prognosis is going to be. So in this case, this, nowadays this is a very fast road to brentuximab vedotin, which is, it's not just a monoclonal, but it's monoclonal with a toxin attached. So it binds to the CD30 cells and it has a toxin attached, so it kills them. So Brentux is your new monoclonal for CD30, and it's kind of tailor-made for the aggressive spectrum of CD30 lymphoproliferative disorders. You'd never use it for something like lymphomatoid papulosis. You use it for something like transformed MF. So that's brentuximab. Okay, so this is tumor stage MF that's not transformed. So tumor stage MF, you still have epidermotropism, right? You still have portrait microabscesses. A little bit of spongiosis, but it's really not as much as you'd expect for the number of lymphocytes. Papillodermal fibrosis, so all of this looks like MF. And then those same atypical cells just keep on going. So instead of being benign recruited lymphs below, it's the same large atypical dark cells all the way through, but there's no transformation. So is Brentux going to work for this?
Mm-hmm.
Curiously, occasionally it works for tumor MF that even if it doesn't express CD30. And it's probably like somewhere intracellular, it's starting to express that CD30. You can't tell yet with stains, but it does work for some things, for some tumor MF that is not CD30 positive, presumably yet, right? So it's tailor-made for CD30 positive, and for the first few years it was out, everyone said, well, you'd never use it in tumors stage without CD30 until some people tried it, and it sometimes works. Right. So there's presumably cases where there's CD30, but it's not expressed on the surface yet. Right? So how is it binding it? Who knows? Here's another, this is a folliculotropic MF. You can see that's all that's left of the follicle. You've got this massive infiltrate of atypical cells. It's also around the eccrine coil. When it's around the eccrine coil can get really atypical and look like eccrine carcinoma. That's called syringolymphoid hyperplasia. It's not eccrine carcinoma. The eccrine bit is all reactive. It's just syringotropic MF. So you can have syringotropic MF, you can have folliculotropic MF. One of the clues to lymphoma is, see how that's kind of onion skin rows of lymphocytes around the vessel? That's something lymphoma likes to do. You have highly atypical cells. You'd expect you'd probably have EOs in there because this is folliculotropic. And this is folliculotropic going to tumor. Right? If it were early folliculotropic, they'd all be within the follicular epithelium. This is getting ugly, more advanced. Let's see. Let's look there. Okay, so you've got scar, lots of scar, right? In fact, all you see is scar. And this is someone who was diagnosed with factitial disease because she would come in with these healing ulcers and scars, and there was never any primary lesion of any sort, and she was weird and squirrely, and there was weird family dynamics, and then she developed a big tumor that was ALCL. And so sometimes, by the time she got into derm, it was always regressing. So lymphomatoid papulosis is papules of highly atypical, usually CD30 positive cells, other than the different types of LYP. And each one regresses and goes away. ALCL is the same thing except they're tumors. So there's really no difference between ALCL and type C LYP. They're the same thing. They used to call it lymphomatoid tumorosis instead of lymphomatoid papulosis. So massive hyperkeratosis, epidermotropic infiltrate, not a lot of spongiosis for the infiltrate. The lymphs are weird sizes and shapes, right? So they're atypical. Atypia continues into the dermis, and you have lots of visible nucleoli. That's probably CD30 transformed. Brentuximab would be great for that one. Just running through some examples here because lymphomas are different. Okay. How about this? Let's look up first at the epidermis. Is the epidermis involved? No, nothing, right? You've got a massive infiltrate. Do you see a lot of collagen preserved? Or is the collagen kind of pushed out of the way?
Being pushed out of the way.
And you got sheets of large cells with visible nucleoli. Could this be transformed MF? Well, it could be, but I'm looking for any background of MF and not seeing it, right? So this is more likely a large B lymphoma. Sheets of cells, pushes the collagen out of the way.
Type C LYP is sheets of cells too, but they're big.
They are large, atypical. They'd be CD30. So first thing you'd probably do with this is get a CD30, get a B marker and a T marker, right? This is going to be CD20 positive, negative for CD30, negative for T cell.
Are these all the central cells?
These are not centrocytes, but centroblasts and immunoblasts. So a centrocyte is cleaved.
Yes.
So it looks like the letter C because it's cleaved, and a blast is round. Put a vertical stem on that, you got a B, right? So a blast is round, a site is cleaved like the letter C. Immunoblast is a central nucleolus, centroblast is the nucleolus stuck to the side. You'll hit that again next week. So just introduction, because one of the things is how do you navigate through, is it a B, is it a T? Well, we have markers and we have pattern, right? So if that were on the T side, you're right, about the only thing it could be is like an ALCL, right? So you do markers. Is that CD30 positive? No. Is it CD20 positive? Yes. Okay. And then you want to know, those look like everything is centroblast, centrocyte, because it looks like follicle center. Doesn't look like the cells at the periphery. So if you look at a normal germinal center, the center are big cells with vesicular nuclei and visible nucleoli. Then you get the marginal zone, which are small gray cells, cleaved nuclei. And then beyond that, you have round cells that look like a regular lymphocyte. That's the mantle zone. Mantle lymphoma looks like expansion of little round, dark lymphocytes. Marginal zone, gray, mid-sized to small cells, vertically oriented like adnexal structures. Follicle center, big sheets, look like the center of the follicle, centrocytes, centroblasts, immunoblasts. Okay, so that will all make sense next week. For this week, you just have to distinguish B pattern from T pattern. This one, is this a B or a T pattern? T. Epidermotropic, little spongiosis, papillodermal fibrosis,
Bare underbelly.
bare underbelly sign to the vessels.
So it's looking like MF.
And are these cells, they're large and dark, but are they larger and darker than those? Or are these large and dark too?
I think those are large and dark also.
And so that means this is not just patch, this is going on to plaque. And so one of the other things for MF, see how you have, let's get that centered here. See how you have ropey red collagen with lymphocytes on each side of it? If you have lymphocytes lining up between strands of ropey red collagen in the papillodermis, that's MF. So strands, sometimes they call them linguini collagen, or just ropey red collagen with lymphocytes lined up between them. That's an MF pattern. So, really nothing epidermotropic, but there's a lot of papillodermal fibrosis. Lots of EOs, lots of large atypical lymphs. The papillodermal fibrosis is a clue that this arose out of MF, but then you're going to mark it, right? Is this transformed tumor stage T lymphoma, which is what it is, or is it B lymphoma? B lymphomas don't tend to give you papillodermal fibrosis. Also don't tend to give you EOs. EOs are not a feature of a B lymphoma, they're a feature of an advanced tumor stage T lymphoma. If you have something that looks B cell in pattern, but has lots of EOs, it's probably benign reactive. T cell in pattern, tumor stage, EOs, malignant. B cell in pattern, big nodules, EOs, benign reactive. Okay, next week we'll hit more leukemias, and next week it'll be a mix of B and T and leukemias, and it's, which one is it? Or is it benign? Because there'll be benign reactive lymphoid hyperplasias in there too. Okay.
Thank you.
So for T lymphomas, you can tell a lot by pattern, right? So you can look at something and say that's probably MF. For B lymphomas, you need markers, right? So if you were crafting a question about B lymphomas, what can you test? Markers, right? So that whole alphabet soup of markers, you got to learn them, because when you get a report back, the report's going to say, well, this is CD20 positive, BCL6 positive, blah, 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 blah. You got this whole phenotype. That's telling you what it is, right? You have to be able to interpret that report because you're a derm. So you got to know the markers and what they mean. It's not that hard. When you go through you just have to go through them a few times and memorize them. It's not that hard to do. Okay, done.
Thank you.
And we are frozen there.
Oops.